Hello, folks. Hello, folks. Thanks for coming. I didn't realize how many people had come in the span of me trying to figure out our computer woes. Clearly not technically savvy. So I'm Vincent. I'm one of the anesthesia residents that's moved here from emergency. And today we'll talk about the direct anticoagulants, their reversal options, maybe a case of putting the cart before the horse. So we'll talk a bit about, as I said before in the introduction, the oral anticoagulants that are currently available in Canada. We'll discuss some of their monitoring options and explore sort of current and upcoming options for the reversal, as at least one antidote has been approved by the FDA in the United States, albeit. First, the indications for direct oral anticoagulants, by far the most common with regards to our patients, is probably non-valvular atrial fibrillation, but it's also been touted in the treatment of pulmonary embolism and DVTs, as well as PE-DVT prophylaxis post-operatively for major hip and knee surgeries, which could make things a little bit more interesting post-operatively for our patients. Specifically with regards to atrial fibrillation's most common dysrhythmia, affects a number of people, and the risk factors for atrial fibrillations are definitely present in the patients that we see perioperatively, which probably increases the tendency for us to see atrial fibrillation in our population. When we look at the Canadian Cardiovascular Society guidelines in terms of the management, they use the variation of the CHAD score and the CHADS2 VASC score to determine who's going to be put on oral anticoagulations, or oral anticoagulants, I should say. It's easy to see that you don't need that many criterias in order to go on oral anticoagulants. So according to the Canadian Cardiovascular Society, if you're over the age of 65, you'll get oral anticoagulation, as well as if you have a prior stroke, high blood pressure, heart failure, diabetes. So you need to basically be previously healthy with no other issues with atrial fibrillation under 65 in order to avoid oral anticoagulation, which means a lot of our patients are going to end up on oral anticoagulants. Up till recently, we had warfarin as an option for oral anticoagulants, or coagulants. It's well known to us. It's a vitamin K antagonist, but there were a lot of factors influencing the INR, making monitoring and prescribing difficult. Dietary vitamin K, undisclosed drug use, poor patient compliance being one, alcohol consumption, which never happens with our patients, liver disease, advanced age, and a number of medications would either enhance or inhibit metabolism, leading to wildly erratic numbers at times on fairly simple medications. The beauty of it was we had some decent reversal options at hand. Vitamin K would take days to work, but it could make reinitiation more difficult. Of course, we don't have to deal with that as much from our perspective. There's a transfusion risk with FFP, and prothrombin complex concentrates were available when rapid reversal was needed in a life-threatening situation related to oral anticoagulants or warfarin. That led to, I never realized that the screen was this small. Doesn't matter, because this is just to emphasize that we had a sort of fairly well-established approach to the management of warfarin and their reversal in terms of when to stop it preoperatively, in elective and emergent surgeries. And hopefully at some point we'll get to a similar sort of algorithm with regards to the direct oral anticoagulants. Some of the disadvantages I'd hinted at earlier are delayed therapeutic levels with warfarin needing bridging initially, narrow therapeutic index, which made prescribing at times difficult depending on the INR, food-drug interactions, drug-drug interactions, and finally, and more importantly, according to folks or proponents of direct oral anticoagulants, frequent monitoring, which led to the development of direct oral anticoagulants. At the present time, we have rivaroxaban and apixaban, which are direct factor Xa inhibitors, and direct thrombin inhibitors in the form of dabigatran or Pradaxa. Incidentally, the first one to have come out and has an antidote that's been approved by the FDA, which we'll talk about later on in the presentation. The point in the coagulation cascade where, sorry, the screen doesn't work, where the oral anticoagulant, direct oral anticoagulants are acting is shown on the diagram below. Their advantages: they're sort of fairly rapid in onset, have a short half-life, they have decreased drug-food interactions compared to eating cabbage when you're on warfarin. They have a wider therapeutic window, and as such, the thinking is that there's not as much of a need for routine monitoring. Of course, these apply more to the population at large, and in our patients, it might be worthwhile having some options for monitoring. So we'll discuss that in a little bit. It's important to realize that we need to either reduce the doses in patients with decreased renal function, especially with regards to dabigatran, which is more dependent on renal clearance than rivaroxaban and apixaban. In advanced aged and low in patients with low body mass index. Incidentally, in severe renal failure, it might be worthwhile discontinuing the direct oral anticoagulants, or at least the dabigatran. With regards to outcomes related to stroke prevention in atrial fibrillation, direct oral anticoagulants have demonstrated decreased intracranial hemorrhage. This sentence that I loved going through while reading these papers: non-inferiority in terms of strokes and systemic embolism compared to warfarin, and potential decreased mortality as well. Bring you back to the Canadian Cardiovascular Society guidelines with regards to oral anticoagulants. Just to highlight a little note in the subtext that at this point they suggest using the novel oral anticoagulants, what I've been referring to date as the direct oral anticoagulants, suggesting that they be used in preference to warfarin in non-valvular atrial fibrillation, which means they're here to stay, and we need to sort out how to manage them perioperatively. First off, dabigatran is an antithrombin direct oral anticoagulant. The dose is 150 milligrams twice a day in atrial fibrillation. I've just sort of focused on atrial fibrillation. There are different dosages for pulmonary embolism. But just note the decreased dose in renal failure and the renal clearance, which is high for the bigatran, and it behooves us to be cautious in renal failure. The half-life as well compared to warfarin is much shorter, 12 to 14 hours, and there's sort of 35% protein binding, and I'll allude to that a little bit later in terms of how we're going to deal with the reversal or at least mitigating the effects of the direct oral anticoagulants. Rivaroxaban, again, reduced dose in renal failure, a little less renal clearance, a bit faster onset, much more protein binding, which makes it not amenable to dialysis, which is an option in terms of reversal of the bigatran. Finally, Apixaban, anti-10A as well, like Rivaroxaban, requires reduction in dose in renal failure, albeit has more metabolic pathways, and so it's less dependent on renal clearance. Liver failure can affect the duration of action of Apixaban more than the other two. And again, more protein binding for Apixaban makes it less amenable to dialysis should the need arise. Some of the disadvantages, it kind of goes without saying, but it increases the surgical bleeding, which is probably the most important thing from our perspective. A couple, dabigatran and rivaroxaban, have demonstrated increased GI bleeding in clinical trials. Interestingly enough, less with Apixaban. More importantly, there are no validated antagonists up till now, for most of them at least, and definitely none in Canada right now. They cannot be monitored, or at least not easily yet. Of note, these medications are being touted for atrial fibrillation, and some of the medications patients will be on for atrial fibrillation can lead to prolonged anticoagulation action of the direct oral anticoagulants. These medications include verapamil, diltiazem, amiodarone. So where does that leave us in terms of when to stop? Do we need to bridge? When do we reinitiate the anticoagulants? And finally, and more importantly, in an emergency, how do we reverse these medications? So we'll start with when to stop. Obviously, that's predicated upon bleeding risk. I apologize. I thought the screen was a bit bigger. Bottom line is open abdominal procedures are obviously going to bleed more than sort of minor dental extractions. And that will guide us in terms of when to stop and how far in advance to stop. Recommendations. There's a number of review articles looking at the evidence, and I've tried to sort of sum it up. We'll also discuss the ASRA recommendations and the provincial recommendations in terms of when to stop our medications preoperatively. But according to the Canadian Cardiovascular Society, we should stop them in low-risk patients with regards to the anti-10A inhibitors 1 to 2 days preoperatively. In high-risk bleeding cases, 2 to 3 days. I already know what you're thinking. It may not be enough, but we'll chat a little bit about that. With regards to the bigatran, use the upper end of those days if the patient has mild renal failure, moderate renal failure, add a day, and finally add another day in severe renal failure. Hopefully our patients aren't going to be on this in severe renal failure, but we all know that our patients perioperatively can have changes in their creatinine clearance acutely, So it's not hard to imagine that we'll have to deal with patients on dabigatran and severe renal failure that may not have been previously. I want to highlight the sort of 3 and 5 days in terms of the high-risk bleeding with regards to rivaroxaban, apixaban, and finally dabigatran and severe renal failure, as that's similar to the recommendations with ASRA with regards to neuraxial techniques. ASRA recommends 5 days, discontinuation of 5 days of dabigatran before insertion or neuraxial techniques, 3 days for both rivaroxaban and apixaban. The provincial guidelines are based on some prospective cohort studies. They're similar in terms of days in standard or low risk of bleeding with normal creatinine function. In dabigatran, they recommend 24 hours, 2 days for high-risk bleeding, moving up to 4 days in moderate renal failure and 6 days, waiting 6 days in severe renal failure with dabigatran in a procedure that's at high risk for bleeding. With regards to rivaroxaban, the renal failure isn't as critical as it's less renally cleared. The recommendation is 4 days in severe renal failure in the presence of rivaroxaban. And these are, by the way, what's also the provincial guidelines for AHS in terms of when to stop them. When to bridge, less even evidence. Of course, we're trying to balance the thrombosis risk with the risk of bleeding during the procedure. Patients at high risk of thrombosis include patients with high CHAD scores, recent embolic events, either DVT, stroke, or mechanical mitral valves. In those patients, it probably behooves us to consider bridging. Unfortunately, there are no prospective trials that have looked at bridging specifically. Some patients or some papers will even recommend not bridging, at least in the patients that are at low risk of bleeding and low thromboembolic rates, or risk, sorry. In patients with renal failure, though, that are going to undergo a moderate to high risk of bleeding, a procedure that puts them at moderate to high risk of bleeding and have a high thrombotic risk, it may be important to start considering bridging with either low molecular weight heparin or heparin. Of course, when to initiate the low molecular weight heparin and heparin is a bit difficult because we're not quite sure when the effects of the direct oral anticoagulants have subsided, especially in patients with renal failure, which I'll discuss when we talk about monitoring. When to restart. Various review articles and societies will suggest 24 hours in patients that have low or undergone a procedure that had a low risk of bleeding, 48 to 72 hours, or until complete hemostasis has been achieved. Of course, we have to bear in mind whether or not the patient is immobilized postoperatively, if they can have medications by mouth, and we're all well aware that postoperative renal function can fluctuate quite a bit, which should make us a bit cautious with regards to the reinitiation of direct oral anticoagulants postoperatively, especially in hospitalized patients. Monitoring, as I alluded to previously, would be helpful for us in patients that are acutely bleeding or requiring a urgent procedure. In the more general sense, patients that have had experienced a thrombotic event despite treatment or overdose could be other emergency reasons for monitoring. But it would be also probably important to monitor routinely in patients that have chronic disease, chronic kidney disease, I should rephrase, as we know that it will prolong the effects of the direct oral anticoagulants. With regards to dabigatran at this point, monitoring options are qualitative. We can use the the PTT, and the thrombin time, which is available in regional and urban and regional stroke centers in Alberta, to give us an idea of whether or not there's significant residual anticoagulant effect. So if your PTT and thrombin times are normal, the recommendations at this point are that you probably don't have significant residual anticoagulation effect. It's probably not super comforting when we're about to do major surgery or considering neuraxial procedures in these patients. Quantitative tests are coming down. The dilute thrombin time is able to quantify the amount of dabigatran left, but it's not currently available in Alberta, at least according to the guidelines. With regards to anti-10A inhibitors or anti-10A medications, in this case, the PT can be qualitative in terms of a normal INR PT can give us an indication that there's probably not much residual oral anticoagulant effect left. Quantitatively, there is an anti-10A assay that is currently available. I'm not aware of the turnover time with regards to that test, and consulting hematology might be worthwhile in these cases. So there is an option for quantitative testing with regards to anti-10A medications such as rivaroxaban, apixaban at this point. Obviously, a lot of things are in flux with regards to these medications, and tests are being developed, and further tests will probably become available in the near future with regards to monitoring these medications, which may help guide us in terms of when to stop, how to bridge, when to reinitiate, and more importantly, guide us in terms of reversal of the medications as well. Once we are able to determine quantitatively, I should rephrase, what the level of the medications are, the recommendations, which may change by then, are that under 30 nanograms per mils, we can operate. We're encouraged to wait 12 hours in levels above 30, and consider dialysis with regards to dabigatran when the number is over 400 nanograms per mil. We'll discuss the approach to reversing agents fairly soon here. What do we have for reversal options? So we can try and reduce the intestinal absorption, increasing the clearance of the medication, blocking the site of actions, which is showing some promising results in clinical trials, increasing the drug's target through prothrombin complex concentrates, and more generally trying to improve the coagulation status. Before I go on, a lot of the last-ditch efforts in terms of reversing these agents have been done either in vitro on animal models, but there's very limited human studies with regards to the reversal options with regards to prothrombin complex concentrates. Activated charcoal relies on the medication still being in the gut, which means we need to give it fairly early, especially with regards to the bigatran, which doesn't remain within the gastrointestinal system for very long. So as part of our history with regards to managing these patients, it might be worthwhile finding out when their last dose of the medication is. Up to 6 hours with apixaban, which has a slightly longer abdominal or gastrointestinal transit time. These, again, it's important to mention that these were in vitro as opposed to in vivo experiments, but in a patient who may not require sort of imminent intubation, it might be worthwhile to consider, of course, in our patients. Activated charcoal, maybe we may wish to sort of delay or not use it. Hemodialysis, again, I'd mentioned before for dabigatran only, because of its low protein binding and the fact that it's mainly renally cleared. Interestingly, you can get a rebound of concentration because of redistribution of dabigatran after hemodialysis. In patients that are acutely bleeding, requiring urgent surgery, it's obvious that it may not be the most practical option in terms of getting sort of central vascular access, the time required for hemodialysis, but it is an option in a patient that's relatively stable, awaiting urgent surgery that can wait. In whom, obviously, you're worried with regards to prolonged effects of the oral anticoagulants. Supporting the coagulation with tranexamic acid, again, limited studies. Consider in all direct oral anticoagulants at 10 milligrams per kilograms IV as per the provincial guideline recommendations. Prothrombin complex concentrates can be considered as last-ditch efforts in patients with life-threatening bleeding that require surgery, or in that require surgery or have life-threatening bleeding. With regards to PCC, we should consider it in anti-10A medications like apixaban and rivaroxaban at 25 to 50 units per kilogram or 2,000 units. With regards to dabigatran reversal, some studies show promise with regards to activated PCC. The options available are FIBA here, which contains the factor VIII inhibitor bypassing activity, as well as the factors contained in PCC in various inactivated and activated forms. It's important to remember that while we're trying to deal with their patients' coagulopathy, these medications can have a thrombosis potential when used, as well as recombinant factor 7A. Consider its use in anti-10A, antithrombin, when patients are on anti-10A and antithrombin medications. At a dose of 40 to 90 micrograms per kilogram, again, thrombosis potential in those patients. activating the or using these medications should probably be done in concert with hematology. I'll discuss that in a little bit. But where does that leave us with regards to what to do? Unfortunately, a lot of it is sort of back to sort of basics in terms of supporting their ABCs, considering activated charcoal in patients with mild bleeding who aren't requiring sort of imminent intubation. And in mild bleeding, perhaps just stopping the medication and waiting, as we know that they have a short half-life, and hopefully the effects of the direct oral anticoagulants will wane. In moderate bleeding, we should basically do what we do with bleeding patients, get good IV access, transfuse blood products as required, support their renal function in the hopes that we can help clear the direct oral anticoagulant, consider surgical control of bleeding, bearing in mind that surgery in and of itself will increase their bleeding, of course, and for Neathling, who says that emergency physicians do the airways, breathing, and consultation, I'd probably recommend discussing with hematology or transfusion medicine fairly early with regards to the massive hemorrhage protocol, especially if we're going to take them to the operating room, as it'll probably be necessary. Consider tranexamic acid in all oral anticoagulants, and again, hemodialysis and dabigatran if time permits. For life-threatening bleeding, in addition to what I'd mentioned previously, again, PCC and anti-10A and dabigatran, perhaps activated PCC is preferred in dabigatran from very limited studies. Consider recombinant factor 7A in cohort with transfusion medicine. And finally, consider the antidote for an activation when it becomes available. To date, there is one antidote available in the United States through special permission of the FDA, and it's to dabigatran. It's a monoclonal antibody fragment. As you can tell, my French accent comes out a lot more when I'm speaking in public. I won't even bother trying to name this medication. Idarucizumab is the best I can come up with. Bottom line is it binds dabigatran both in the free form and thrombin bound, and inhibits basically dabigatran's action. And this is done, this happens fairly quickly. I'll chat a little bit about this, but the complex itself is renally excreted. At a dose of 5 grams IV is the current recommendation. So it was FDA approved under the accelerated approval program. I didn't know such a thing existed until recently, for drugs for serious conditions that have fill an unmet medical need. Just highlighting the fact that obviously the some of the advantages in terms of monitoring of these medications have led to pushing for these medications, but from our end, it can lead to some serious issues, which hopefully will be remediated in the near future. The company, despite this approval, still needs to provide further information with regards to the drug's clinical benefits. But it provides patients with earlier access to promising new drugs. With regards to dabigatran reversal, within 4 hours, 98% of patients that were actively bleeding that were recruited in the trial, and 93% of patients that were requiring emergency surgery showed normalized quantitative test that I was discussing before, the dilute thrombin time after the administration of 5 grams of the monoclonal antibody. Interestingly, note just in the, I don't know that you can see it, but this effect persisted to 24 hours and on these patients. Options for, so that gave us an option for antithrombin or dabigatran. What about the anti-10As? There are a couple of options. One is, again, another unpronounceable medication that's a modified factor 10A. It binds anti-10A but does not activate the coagulation cascade. Because of its short half-life, it's administered as a bolus and an infusion. In fact, return of anticoagulant activity can be expected a couple hours after stopping the infusion. So in our case, we'll probably have to continue the infusion in life-threatening bleeding patients requiring surgery. We'll have to continue the infusion probably intraoperatively. It's not available yet, but in sort of early clinical trials, it's reduced anti-10A activity in 92% of patients given apixaban versus 33% for placebo, and 97% of patients on rivaroxaban. Finally, the panacea for all direct oral anticoagulants, a non-covalent cationic molecule that targets dabigatran and anti-10A anticoagulants. At this point, it's been administered in animal studies, and there's been no sort of adverse events, but we're basically in very, very early phase with regards to this medication. Of course, its indications for use will probably be related to our same indications for PCC and life-threatening bleeds, and guidelines will be developed as these antidotes become available. So, to summarize, direct oral anticoagulants are here to stay. For better, for worse, we'll need better information, and we'll need to stay tuned with regards to details surrounding their perioperative management, specifically issues addressing bridging, reinitiating the medication, post-op prophylaxis, as well as when and how to use the new antidotes. But bear in mind, for now, while we don't have any antidotes, that pre-op interruption should be based on renal function, especially with regards to dabigatran. Current and frequently used blood tests like PTT and PT can help us qualitatively, albeit not quantitatively, just yet. Quantitative tests exist obviously for both and are available for anti-10A at the present time in the region. And bleeding emergencies, really focusing on the basic principles involving transfusion medicine, as we'll likely need a massive hemorrhage protocol in patients that have life-threatening bleeding, require surgery, and/or require surgery. Thank you.